Good afternoon. So today my topic will be the performance measurement for the management of heart failure among the acute coronary syndrome patients in China. The paper published last year is actually summary with the change from 1990 to 2010 in China. The disease pattern change. For the change, you can see most of the major cardiovascular disease, actually the age standardized mortality rate reduced, include especially stroke. But the one of increase is ischemic heart disease. So this side. So the substantial decrease for the cerebrovascular disease, the disease, a little increase for the coronary heart disease. But this picture actually is not really reflect the burden because most people, they have stroke, they now die, they survive. There is many stroke patients, they survived, then they need a secondary prevention, include a myocardial infarction patient. So this paper is a collaboration with Columbia University. So we actually predict the number of cases, the non-fetal and the fetal in next 20 years. So you see the coronary heart disease and the stroke, the increase a lot because the blue part is the population aging. The red part is because the increase the risk factor. So that means even the mortality reduced, we're going to have a big burden. The patient, they survive, then they need a secondary prevention. If you see the experience from a Western country, the one professor from Liverpool University, Professor Simon Keppel, he actually used the impact model to modeling all the experience from Western country because most of Western countries have decreased mortality CHD. So what is the major explanation for reduce the mortality rate? So the right color is different countries like Ireland, many Finland, it's Sweden and US. Actually we did in China too because China have increased the mortality rate, used to. So you see the right part is basically from primary prevention. The blue part percentage is varied different country, but from a secondary prevention, that means the experience from a Western country for many, they have already experienced a decreased mortality rate showing how successful for the primary prevention and the secondary prevention. And also the evidence-based medicines, the arrow currently in China, so even the evidence, most RCT still is based on the Western population, but more and more Chinese join the international RCT with the evidence specifically for Chinese people. This is based on the 2014 update. China actually have big number of patients currently join different international RCT to get more and more evidence. And also there is many guidelines published from China compared with even the number is more than the ESC published. I need to update this number, but it's a little bit outdated. But I mean, we have experienced how they reduce the mortality in the other country. Then we have more and more evidence, then we have a guideline. But many papers, unfortunately, published in China to measure the situation. Secondary prevention is how we use those evidence in clinical practice. It's showing that it's really not so good. So this study, the published in Chinese Journal of Cardiology showing in China 65 hospitals, the name is bridge, trying to bridging the gap between the guideline and practice. You see that for the secondary hospital in China, we have over 7,000 secondary hospital, is over 1,000 tertiary hospital. So the primary PCI performing only 2.5% for the people, STEMI patient. So it's still for the secondary hospital, even a little bit high for the thrombolysis, but still much less patients receive the reperfusion during the acute period. And also another study showing how the high-risk people have very low rate achieved target, relative still low the percentage used starting for the patient they should use. And another study showing the treatment situation for atrial fibrillation. So you see the patient, they use nothing. It's not used warfarin. So in 97.3%, it's most of they're not use this medication. Only 2% use for aspirin, and also other for the atrial fibrillation. The situation is really need to improve. And also the other study that published this year showing how the community, that when the patient go back to community for this side is for ischemic heart disease, is for stroke. So very few percentage they use. They said they divided the patient according to the education level, but you see whatever level education, the percentage of starting use for diuretic for the use for ischemic heart disease is relatively low for ACEI and aspirin even. And the pure study, they compare different part of the world, the performance, secondary prevention for the patient in community. You see the China and compare with, here is Malaysia, Africa. China have very low performance for compare with the country in North America and Europe. So the major barriers in secondary prevention is a low utility of evidence-based treatment. How can we improve the situation? So can we educate the doctor? So one trial is conducted in China, they published this year. Actually, after you education the doctor, it's almost useless. It's not show real how you improve the performance for the doctor education. Another study they published on stroke, also trying to educate a neurologist by the training course. They divided into two parts, but still not show the significant impact when you only educate the doctor. So there's many major barriers to the 5 key system-level barriers to effect the implementation is the leadership support for implementation, quality improvement, and variation in the capacity of clinical service and quality improvement resources. Fear, that in China, the relationship between doctor and patient is currently sometimes very different with other countries. So the doctor is just the fear of the patient with some dispute doctor, and also the healthcare, the funding construction, the constraints and the high out-of-pocket expense, other patient-related factors. So should we use some other way? Because in U.S. they use guideline. This program is to do the assessment first. Then they have quality indicators for quality of care. Then evaluate those quality care indicators and they feed back to the doctor. So it's kind of continue quality improve the program. So their experience is very successful in U.S. Can we use that? So they have very clear indicator for AMI, the performance indicator, and the performance for atrial fibrillation. And also their report, each achievement measure to the doctor, to the chief doctor. But if you go to see the publication, the one paper published several years ago, if you compare the level of evidence, the current is 90% for AMI, the evidence is at least the B level. But if you see the evidence for atrial fibrillation, most evidence is not rich, very strong evidence. Most of them is a C level evidence. So how you use that is still not very formed, a very strong evidence that become an indicator for measurement, quality of care. That's a very good question. So how you measure the quality of care for heart failure based on those kind of guidelines, how you translate the guideline evidence into the performance measure. So that's a question. So because the most of the heart failure patient hospitalized in China is the underlying cause is because of the coronary heart disease. So I think that is maybe the one of the position we can evaluate those ACS patients, how they management heart failure among those patients. Maybe is the one way because it's more evidence for them. So the research question is the situation heart failure management among hospitalized ACS patients. So, but actually this paper rejected by many journals because when you're trying to measure the performance, the real world clinical, they don't have enough the very good data. They don't have echo even, many patients don't have echo examination. So we use only the clinical diagnosis, they have a heart failure. So if you use that kind of data, there is not only meet the criteria heart failure in the heart failure society. But anyway, the paper published on the Chinese Medicine Journal is an English journal, but with a very hard journey for publish. But this purpose study is to assess the quality of management acute adult the chronic heart failure inpatient in real-world clinical practice in China. Use a modified ACC-AHA clinical performance measure for CHF. Then this study actually original design is not for the quality care of heart failure, it's for the ACS. So it's a nationwide study, include 65 hospitals, then they have recruited not only the inpatient but also the outpatient. So the criteria for the performance measure, that is the original performance measure for ACC-HA for chronic heart failure. Then we modify a little bit according Chinese guideline heart failure. So there is 6 indicators. So there's a discharge instruction, but include activity level, diet, discharge medication, and the smoking cessation consultant, and also the evaluation left ventricular systolic function, and warfarin for atrial fibrillation patient, ACEI, ARB for discharge, beta blocker discharge for the patient they don't have contradictions. So we use the 6 very simple measurement to see the performance management, the CHF, at the hospital discharge. You see that is 55, is less than the 60% patient receive the discharge instruction. Then less than the 60%, less than 55%, even they even have an echo examination during the hospitalization. And ACEI, ARB use among the patients they have to use because they don't have a contradiction. For both reasons, ACS or heart failure. And the beta blocker for patient, they don't have a contradiction. And the smoking cessation consultant and warfarin, this is a shame, it's only less than 10% among the discharged patient with the heart failure and also atrial fibrillation. Actually, this study, because it's a national study, so you have a chance to see the difference between region and region and see the variation between the central part, the south part have a lowest. Here is the hospital for the patient with the heart failure diagnosis. They did perform left ventricular the echo examination for the evaluation among different regions. The highest is the northeast. The region is 68%, close to 7%, but lowest is less than 40%. So there is various performance. And also, when you put the 4 acute treatment performance measure, it's like a discharge instruction, and LVEF evaluation, ACE-EIRB at discharge, beta blocker at discharge for the patient, they don't have a contradiction. Then you see the very few, the patient received all the 4, only 3, only 2, and many of them is only 1. So there, you see the performance. And also, if you see the 2 combination medication, there's 40%, for the patient, they use at least 1, there is only 20% for the plus together is 100%. Both, only 1, only ACE-EI, only beta blocker, none of them. There's a regional difference between they use all the, that means have a good performance for those 4 indicators. It's still very, even the highest one is only 30%. For the central south part, it's only 10%. And another I know there is less effort to evaluate performance for heart failure because it's not very easy. But another study, they did a better job than our study because I think it's designed especially for the heart failure performance measure in China. They measure actually 1,862 chronic heart failure patients in 20 hospitals in China. They published this year too. Then they use a quality indicator. First is also the evaluation of left ventricular function. Then, but they clear describe what is the denominator, what is the numerator, and the ACE-EIRB and the diuretic, beta blocker, aldosterone receptor, the antagonist, and also warfarin, in-hospital mortality. So they measure those 7 indicators. So for the 1,800 patients, there is a characteristic for the baseline clinical doctor. Then they say for the different indicators is minimal, is 50% percentile. Then 20, they put the performance is like a quartile, the maximum. They see the virus in-hospital mortality among the hospital. There is 20 hospital. This is the number of the hospital numbers, like the number 20 hospital. You see big variation compared with the in-hospital mortality rate. And also they connected the performance measure, yes, no, to the in-hospital outcome. I think the analysis is some problem is analysis, but it's okay. It's just showing roughly how the indicator is related with the outcome. So I think the only one I can find in China, they're trying to evaluate performance heart failure. So in conclusion, the key issue in prevention CVD is how to improve the quality of care in real clinical practice in China. And there are considerable gaps between guideline and clinical practice for management chronic heart disease among ACS patients in China. There is significant variation in performance chronic heart failure management across hospital and regions. A quality report with a proper assessment may be one of the ways to improve the quality of care. Proper indicators for assessment quality of care, heart failure in different level hospital in China may need to develop. Thank you very much.